analgesic drugs. So this is an extension topic, subtopic of our neuropharmacology section. So analgesic drugs are drugs that produce a decreased sensitivity to pain. Right? They're a very broad category of drugs. Similar to or related to the analgesic drugs are anesthetic drugs. Now, the anesthetic drugs, you also have a loss of pain sensation, but more importantly, you have a loss of other sensations. Okay? So, oftentimes, with an anesthetic drug, you will have loss of pain, but also of any kind of touch sensation. Okay, so it tends to block transmission at all, sensory transmission in all ways. Okay. So we'll talk about drugs that many drugs will have analgesic effects, but no anesthetic effects. Anesthetic effects, but no, but mild analgesic effects, and some drugs have both. Okay, and we'll talk about these drugs. So one thing that I recommend, just as a reinforcing background thing to do as we're talking about these pain drugs, is to go back and maybe review the pain lecture that I recorded for fundamentals. So you will see no questions on the exam about substance P and sensitization and primary and secondary region, but it might be just helpful to remind yourself just some of the aspects of pain. You know, that pain is both a sensory feeling, and also there's an affective part of pain. So, you know, if you want to go back and rewatch that, it could help. Because I'm not going to talk about the physiology of pain in this lecture, because you've already covered that in fundamentals. Okay? Or I already covered it in fundamentals by proxy, remotely. Okay, so we're going to talk first about the local anesthetic drugs. So local anesthetic drugs are designed to suppress pain. That's our target. Okay, suppress pain by blocking sodium channels, okay, and blocking conduction of action potentials along axons. Okay. So local anesthetics often remove pain, but they also tend to remove, in that area, tend to remove sensation and control of movement as well. Okay? So you tend to have both loss of painful stimulation, loss of fine touch, you know, pressure, and also loss of control, motor control of the area as well. I saw a hand up over here. Yeah.
Yeah, you said when we started the beginning of this lecture that anesthesias are related to analgesic drugs. Are they analgesic drugs, or are they kind of separate?
So, so there are drugs that are described as having both anesthetic and analgesic, meaning that they reduce both pain and also broad sensation. And then there are drugs that actually block broad sensation but don't overtly block pain. Okay, so they tend to be overlapping, but for some drugs they tend to not overlap. It'll make more sense as I go through. Yeah, I mean, it particularly becomes an issue when we talk about general anesthetics, because when you're inducing general anesthesia, you're inducing unconsciousness, right? But if the drug doesn't reduce pain, then you actually have to add an analgesic drug to complement it. Do you know what I mean? So being unconscious but you're in pain doesn't help, right? I mean, it doesn't. You don't interfere with the surgeon, but you know, You don't want to do that. So it'll make more sense when we get to the general anesthetic drugs. So with local anesthesia, we're only blocking transmission in a very isolated part of the body. Okay? And it could be very small, right? Or it could be larger, meaning potentially the lower half of your body, right? Or it could just be, the right side of your jaw when you're going in for dental work. Okay? So we're suppressing pain, we're blocking sensation without depressing central nervous system function. Okay? We don't have any loss of consciousness or reduced consciousness. So the local anesthetics tend to come in two chemical categories. We've got the esters and we've got the amides. Esters come in the form of procaine or novocaine. That might be a trade name to remember, Novocaine, although you probably already know it. And the amide drug, most commonly used, lidocaine. And actually, lidocaine is the most common local anesthetic drug that's used. Okay. These local anesthetics are often used along with a vasoconstrictor. And the vasoconstrictor of choice is usually epinephrine. And the purpose of the vasoconstrictor is to prevent distribution of this local anesthetic to the surrounding tissue. Because by maintaining a high local concentration, it allows that drug to act for longer. Because usually the drug stops working when it diffuses and the concentration is too low to be able to block transmission in that particular area. Okay. Now, the adverse effects when we use local anesthetics are usually because of the vasoconstrictor. Okay. We normally put in a very small amount of the vasoconstrictor, and we avoid major blood vessels because we don't want the vasoconstrictor to gain access. We don't want the epinephrine to gain access systemically. Okay. So the adverse effects, if they're going to happen, are usually because there's some spillover into the systemic circulation of the vasoconstrictor. Okay. So we tend to see things like palpitations, tachycardia, nervousness, hypertension, okay, if we're going to see it. Has that ever happened to anybody? You go in for dental work, and then all of a sudden your heart's racing and that kind of thing? Yeah. It's happened to a few people I know. It's never happened to me, but it's very alarming when it happens because you just feel like, oh my God, I'm dying, right? You're going in for dental work, and then all of a sudden, for but it's like 3 seconds, right? It's the most horrifying 3 seconds of your life. But it's because the epinephrine has reached systemic levels, but normally it's such small amounts that it's very short-lived. Right? But it could be real problems for somebody who maybe has cardiovascular disease or pre-existing problems. So it's very rare, but it can happen. If the effects are more significant because the dose of epinephrine was more, an alpha or beta adrenergic antagonist can be used as kind of an antidote to block the effects of epinephrine. But that's not normally necessary with the application of local anesthesia. So procaine was formerly the local anesthetic of choice, but now is much less frequently used. It tends to be available as a solution in different concentrations, 1, 2, and 10% most commonly. Lidocaine is the most widely used local anesthetic. It can be used for both topical and to injected topically, or excuse me, applied topically or injected locally. Okay, and the effects are extended, as I mentioned, by epinephrine. And lidocaine can also be used to treat cardiac arrhythmias, since it's a sodium channel blocker. Okay? The dysrhythmic drugs are wide and varied, but they all tend to affect sodium or potassium conduction through the cardiac cells. Preparations, there's lots of them for lidocaine. We see creams, ointments, jellies, solutions, aerosols, patches, right? You can go to your local CVS or Walgreens and you can get a lidocaine spray to spray on your cuts and abrasions so they don't hurt so much. If you can get over the initial sting, there's actually a numbing effect after that. There's topical anesthetics that are lidocaine that you can put topically to cause numbing in your mouth. Those lozenges that they have that tend to cause numbing in your throat when you have a really bad sore throat, there tends to be some amount of lidocaine in that, which they tell you not to take too many of at a time, or else you can lose your gag reflex, which is not a good thing. So local anesthesia really has to do with numbing an area, okay? Numbing an area so that you can perform what would be a painful procedure without the numbing, okay? And it can be a small area of the body or it can be a larger area of the body. And it really depends on where you're applying the anesthetic. So we can apply these local anesthetics to the epidural space or the subarachnoid space, right, to produce anesthesia to basically the lower half of the body. And that can be enough to perform major surgeries, right? So C-sections, cesarean sections are often done under conditions like this. Okay? I believe it's spinal in that case. But this is, so epidural anesthesia, you're injecting local anesthetic into the epidural space. It can reach systemic circulation, so that has to be considered. And it's usually lidocaine or another drug that's similar to lidocaine, but you don't have to worry too much about the details of that drug. Okay. So if you're looking at a cross-section of the spine, so this is the back of you and this is the front of you. So you have the ventral body of the vertebral bone right here, okay, and the little spiky part in the back. You have the spinal cord here, and you've got your peripheral nerves coming out of the spinal cord. Your spinal cord is part of your central nervous system, so it has the meningeal layers, right? And the meningeal layers include the outermost layer is the dura mater, innermost layer is the arachnoid mater, and the middle layer is the arachnoid mater, innermost layer is the pia mater. Okay? The epidural space is actually the space outside of the dura mater. Okay? So the anesthetic is put with epidural anesthesia. The drug is put in the epidural space. Okay? And normally the approach is from behind, and so it's in the posterior epidural space. So you can see the approach is from the posterior side, and it's put in that epidural space. Excuse me. Spinal anesthesia, the local anesthetic is actually placed into the subarachnoid space. Okay, so subarachnoid space. Here's showing the epidural space, right? The epidural anesthesia, and then the spinal anesthesia is actually going through the dura mater, through the arachnoid mater, and it's in that space between the arachnoid mater and the pia mater. Okay. And it's a much more potent local anesthesia of the lower portion of the spinal cord. Lidocaine, tetracaine, bupivacaine, these are the drugs that we put in spinally into that subarachnoid space. Major adverse effects when this happens, when we apply these drugs, drop in blood pressure is very common. Okay? So a drop in blood pressure or hypotension is a major effect. We can also get autonomic blockade. So we can end up with a disruption of intestinal function, urinary function, which can cause fecal incontinence, urinary incontinence, urinary retention. Okay. It's not uncommon to catheterize someone who's getting a spinal anesthesia for that reason. Okay. And then another adverse effect is getting what's called a spinal headache, which is a very, very intense headache as a result of the spinal anesthesia. But it's still considered local anesthesia, because you haven't lost consciousness. But usually with both epidural and spinal anesthesia, particularly with spinal anesthesia, you will lose both sensation and motor function in the lower half of your body. With epidural anesthesia, depending on the dose, you may be able to retain some degree of control of your lower body, but maybe not. I saw a hand up there in the back. No? Yeah.
Is there ever accidental insertion of epidural anesthesia as spinal anesthesia, or is the dura mater difficult to penetrate?
You can have accidental puncture into the subarachnoid space, but the person should be skilled enough to not do that. Yes. Yeah. No, there is a chance. Yes, ma'am.
Can you explain again the relationship between the local anesthetics and adrenergic receptors?
Yeah, so local anesthesia, particularly when it's injected into like the tissue space, is often delivered along with a vasoconstrictor, particularly epinephrine. And the idea is to cause to agonize the alpha-1 receptors, right? To stimulate those alpha-1 receptors, and to cause constriction of the area so that the lidocaine or whatever your anesthetic doesn't diffuse out of the area. Okay? It keeps it at the site that you want it so that the area stays numb the entire time that you want it there. Okay. General anesthetics are drugs that produce unconsciousness and a lack of responsiveness to all painful stimulation. Okay? So general anesthesia, in addition to blocking pain and all other sensations, you're also inducing a state of unconsciousness. Okay? So this is not what local anesthetics do. We do not alter consciousness with local anesthesia. Okay, they only blunt pain and sensation in a particular area. So there's two main groups of general anesthetics. We've got inhaled anesthetics and intravenous anesthetics. The inhaled anesthetics are sometimes called volatiles, right? So because they're in a gaseous form. So these general anesthetics are not delivered by just any physician or just any nurse necessarily. It's going to be delivered by either licensed anesthesiologists or certified nurse anesthetists. Okay, one or the two. And who are my anesthesia folks? Any future anesthesia folks? Oh, not too many. It's you study a lot. All right. So there's a lot that goes into understanding safe administration of anesthesia. So it's used for a wide variety of procedures. These are procedures that either require full loss of consciousness or something that is sometimes called conscious sedation. So you're not totally unconscious, but there's usually a lack of sensation to pain and also a loss of memory of the time. So, inhaled anesthetics, there are some properties of what are described to be an ideal anesthetic. And you should know by now that whenever anyone or anything starts talking about ideal anything, you know that there's no such thing, right? So, but ideal inhaled anesthesia would induce complete unconsciousness, right? Deliver full analgesia, deliver full muscle relaxation, so you have complete loss of muscle tone, complete amnesia of the event. The induction would be very brief, it wouldn't take very long, and it's pleasant, right? You're not kicking and screaming into the darkness. It's this, very fast, pleasant move into that area. And then the emergence from the anesthesia is equally brief and pleasant. There's no disorientation. The depth of anesthesia can be lowered or raised very easily and quickly. Okay? It has minimal adverse effects and a very large margin of safety. Okay? So as you can already tell, there's no such thing as this. But in the absence of no such thing as an ideal inhaled anesthetic, general anesthetic, what we do have are what we call balanced anesthesia, where we deliver an inhaled anesthetic and we also give other drugs to compensate for what's missing in the inhaled anesthetic. Yes, ma'am?
I don't know if that just answered my question. So, watch C-sections where the epidural hasn't taken, so they still feel pain, so then they use generalized. Is there a concern of double loss or?
Normally, the drug that's being given in the epidural space is different from the drug that's being given for the general, and so they are complementary, but in some respects they have additive effects. So knowing how much of the epidural has been given will help you titrate how much of the inhaled is given. Yeah, so there's definitely they tend to be complementary, but for where it overlaps, there has to be an adjustment in dose. Yeah. So this balanced anesthesia, employing multiple drugs in addition to the inhaled anesthesia to compensate for the lack of that ideal character of whatever inhaled anesthesia you're giving. So what's very commonly given with general anesthesia is a group of drugs delivered together. So what's often given is a drug called propofol, which is a general anesthetic drug, plus short-acting barbiturates, right? So CNS depressants that have a short life. We also tend to give neuromuscular blocking agents to induce paralysis. And we also tend to give opioid drugs and or nitric oxide for the analgesia. Okay. So that combination of drugs, right, along with the inhaled anesthetic, tend to be most commonly used and induce adequate anesthesia. Okay. So these inhaled anesthetic drugs are CNS depressants. Okay? And if you notice, many of the drugs I mentioned are all CNS depressants. Okay? So they are enhancing inhibitory synapses, so they're enhancing inhibition in the brain. They're blocking excitation of the brain. Nitric oxide, or nitrous oxide, is an exception to this rule. Nitrous oxide does enhance GABA. Okay. But nitrous oxide also has analgesic properties that act in ways outside of that enhancement of GABA. Okay. Inhaled general anesthetics. The pharmacokinetics of these drugs, they are inhaled, so they're taken up by the lungs. Okay. They do reach systemic circulation, okay, but they are inhaled. They distribute to the brain and other tissues, and the volume of distribution really depends on the extent of regional blood flow. Okay? But basically, it's going to go wherever blood is going. The route of elimination is almost entirely through the lungs. Okay? So it's breathed in through the lungs, and it's expelled through exhalation of the lungs. Okay? Metabolism through the liver occurs, but it's very, very minimal. Okay? And these inhaled anesthetic drugs tend to be very lipid-soluble drugs. Adverse effects, because it is a CNS depressant, because it does affect neurotransmission and excitability of cells, it can cause respiratory depression, cardiac depression. It can enhance the sensitivity of the heart to catecholamines. Okay? So when the drug is coming off, you could have this rebound excitation of the heart. An elevation in body temperature, malignant hyperthermia is an adverse effect. Aspiration of gastric contents, okay, which is why patients are required to be NPO or they're not allowed to eat or drink at least 12 hours before general anesthesia to reduce the risk of aspiration of gastric contents. And as a side note, if you've noticed, I think I mentioned this in the beginning of the summer, that nearly every patient in the hospital is on Nexium, right? Or so many patients are on Nexium. The proton pump inhibitors like Nexium are often also given preoperatively to reduce stomach acid, so that if there is gastric acid comes up or gastric contents come up, it's less likely to cause problems or aspiration pneumonia because the pH is not as acidic.
Just ask, is that the same reason why people after like surgery also are NPO for a few hours, similar to the same reason why before? It's just like
Yeah, so your NPO until your gag reflex has come back and you can control that the movement of it reduces the likelihood of gastric contents coming up. Yeah. Inhaled anesthetics also, some of their drawbacks is that they can be, because they're volatile and they're gaseous, it can be taken in by personnel in the operating room. So you have this sort of occupational hazard for the people in the operating room. And since some of it is metabolized by the liver, it does get to the liver, and there is some degree of hepatotoxicity to the liver with these inhaled anesthetics. Drug interactions with the inhaled anesthetics, remember these are CNS depressants. So analgesic drugs are often also CNS depressants, so there's some interactions there. Any other depressant, any amount of CNS depressant or CNS stimulant that the patient might be on is going to affect how the body reacts to this inhaled anesthetic. The use of opioids and these other CNS depressants help reduce the dose needed for the inhaled anesthetic, which is a good thing. And then pre-anesthetic medications, they're medications given to reduce anxiety, medications to produce perioperative amnesia, okay, and also to reduce preoperative, perioperative, and postoperative pain. Okay? So we've got the benzodiazepines, right, which help reduce anxiety. We've got the opioids for analgesia. Clonidine, the alpha-2 adrenergic agonist. Do you remember that? We talked about that a week ago. The alpha-2 adrenergic agonist can help reduce pain. So that's the application of that. And the anticholinergic drugs also help. They're CNS depressant, and they help reduce that. Okay. We also give neuromuscular blocking agents because we want paralysis during general anesthesia during surgery. So it induces skeletal muscle relaxation. Post-anesthetic medications. So after patients are coming out of surgery, we need to give medications for a variety of reasons. Analgesic, obviously. We want to control postoperative pain. Mild pain, right? Mild pain, acetaminophen is fine. But severe pain, our drug of choice are going to be the opioid drugs. We also are going to use drugs that are classified as antiemetic. Many of the anesthetic drugs and adjunctive drugs cause nausea and vomiting. So the antiemetic drugs are going to control that postoperatively. Trade name worth knowing because it's almost exclusively used is Zofran, most common antiemetic drug that you're going to see. Okay. And then, excuse me. We use, often during surgeries, we use muscarinic antagonists, okay, muscarinic antagonists to slow down the bowel movements, right, and reduce voiding. So we often use muscarinic antagonists during surgery to achieve those things. So often we need to give a drug to reverse that effect. So atropine is often the drug given during surgery to achieve these things. So bethanechol is often used for post-anesthesia to reverse that, since bethanechol is an agonist, right? Muscarinic agonist. So some of these individual inhaled anesthetics, Halothane, so we actually, this is an area where we actually have two prototypic drugs because halothane is the prototypic drug, but it's no longer in use in the United States. Okay. And fluorane is going to be our backup prototypic drug. They're very similar in many ways. And then we've got a few other inhaled anesthetic drugs, including nitrous oxide. It's worth noting that nitrous oxide is more of an analgesic than it is an anesthetic. So it's very rarely used alone as an inhaled anesthetic. Okay? And then we have a variety of obsolete inhalation anesthetics that you don't even need to have recognition of. Okay? So you can ignore that list. Just know that they're obsolete. So halothane, no longer used in the United States, is a very high potency drug. It's a very, very fast on, fast off inhaled anesthetic. Okay? The onset of the anesthesia is very fast, and then the coming off of it is very fast. It produces really weak analgesia. It's a very strong anesthetic, but weak analgesia. And then the muscle relaxation is usually inadequate on its own. So the neuromuscular blockers are often necessary. Adverse effects, as we'll see with many of the other inhaled anesthetics, adverse effects include drop in blood pressure, hypotension, respiratory depression, dysrhythmias, malignant hyperthermia. We mentioned this before, hepatotoxicity and some other effects. The elimination is mostly through the lungs and a tiny bit or a moderate amount through the liver. Isoflurane is going to be our prototypic drug backup since halothane is not used anymore. It has a lot of similar properties. It's very fast acting. It's usually the induction of general anesthesia is usually used. This drug inhaled along with propofol intravenous. Okay? So when the patient's unconscious, the depth of anesthesia can be raised or lowered by increasing or decreasing the dose of this inhaled anesthetic. Okay? Since it's quick on and quick off. If you stop this anesthetic, this inhaled anesthetic, the patients will wake up within 20 minutes. Okay? It has weak analgesic properties, so analgesic drugs are often given along with it. And then the neuromuscular blockers are also necessary because of the weak muscle relaxation. Yes, ma'am?
So influrane and isoflurane are the same thing?
Yes. Yes. Okay. Some of the same adverse effects, as we mentioned before. Nitrous oxide, also known as laughing gas. It's not a very potent anesthetic drug, but it has a very high analgesic potency. Okay? So it's very good at blocking pain, but it doesn't really put you unconscious. Okay? It does tend to have dissociative properties. So nitrous oxide, you will have this dissociation from your experience and amnesia potentially. But it has a very potent analgesic property. It's never used as the primary anesthetic, often combined with others. But delivery of inhaling 20% nitrous oxide has the same potency as pain relief potency as morphine. So it's pretty strong. No serious side effects. There's some nausea that it can cause. The nitrous oxide has a half-life of like 30 seconds. So it can very quickly be adjusted, right? One thing that's interesting about nitrous oxide, we usually think of it as being used in dental offices in this country, but in other countries, particularly in Europe, nitrous oxide is used very widely during labor for pain management during labor and delivery. About 60% of births in Europe, especially in the UK, are supplemented with nitrous oxide. If you've ever seen, what's that show about birth? Call the Midwife. There was an episode about it, but there's like a modern show about delivering babies in the UK, where you see women sucking on this device, but that's what it is. It's this nitric oxide delivery system, and it's got a lot of pros, right? So you don't need an epidural, or it reduces pain to the point where many women don't need to get an epidural. It's self-administering, so it's self-controlled. You regulate the pain relief. The patient can't overdose on it because they can't deliver more than a particular concentration. And it's very rapid on and off, right? So the only some of the negative effects, or the cons to nitric oxide during labor and delivery, is that it can affect your sense of presence for the birth, and also there's some potential residual inhalation by the staff in the room, so which may or may not be bad, but yes, ma'am.
Are you actually allowed to request that, like in the United States, on 5 years?
So that's part of the problem, is that we're just not set up at all for it. So in the United States, there's like 5 hospitals in the whole country that you can actually have it during labor and delivery. It's St. Luke's. They're pretty progressive. St. Luke's is pretty progressive in the stuff it offers, but yeah, it's probably going to be something that is going to trend here. It's pretty much as soon as women learn about it in the United States, it's going to start trending. But it's widely unavailable. Yeah. Okay. So then we have the intravenous general anesthetics. They include the short-acting barbiturates. Okay. Short-acting barbiturates, benzodiazepine, propofol, which is a short-acting sedative drug, etomidate, also a short-acting sedative. Okay. Etomidate is commonly used for conscious sedation. Okay. So it tends to be a drug of choice for conscious sedation. Ketamine, which is also a short-acting sedative, but it doesn't produce true loss of consciousness, but it does have, it's a dissociative drug. And then we have what are called the neuroleptic opioid combinations. These are when neuroleptics, which are drugs that cause, they are tranquilizers or antipsychotic drugs, are used along with opioid analgesia. Okay, so they're used in combination. Droperidol is an example of that. It's actually, droperidol is an antidopaminergic drug. And fentanyl, which is an extremely potent opioid analgesic drug. Saw a hand over here somewhere. No?
That wasn't the answer.
Ketamine is considered a short-acting sedative.
Oh, is there a class of drugs called tranquilizers?
I'm not sure whether there's a true class of drug called tranquilizers. So the neuroleptic drugs, which are tranquilizers and antipsychotic drugs, they are drugs that produce like an indifference to your experience, a complete distance and indifference to your experience. That's all I know. It's the best I can describe it as. Shrek, do you have anything to add to that?
Tranquilizer is sort of an outdated term. So when antipsychotics first came out in the 50s, specifically the dopaminergic ones, they're labeled as tranquilizers, but people have shied away from that terminology simply because there's a lot of stigma associated with it. So you'll hear them as either neuroleptics, which is also becoming an outdated term, or more commonly first and second generation antipsychotics.
Ketamine is not
No.
antipsychotic.
No.
Yeah. You heard that answer from? Okay, good. Yeah. And they're all considered antidepressant drugs. I mean, CNS depressant drugs, or the antipsychotics, or that doesn't cross over.
The lower potency ones have higher sedating effects.
Okay.
So if you think of it in terms of high potency and low potency,
Right.
it'll have varying degrees of CNS depression.
Okay. Fascinating. Okay. Moving on. Any other questions before we move on? Okay. So the short-acting barbiturate drugs, they're administered intravenously. Methahexatol and other barbiturates were the mainstay of anesthesia induction, but they're not used as much because propofol has replaced it largely. They can cause cardiovascular and respiratory depression, and if they are administered too rapidly, they can cause apnea. Just person stops breathing. The benzodiazepines, diazepam, midazolam, induction with intravenous diazepam or Valium. Valium is definitely worth knowing, obviously, as a trade name. It can induce unconsciousness within a minute, so very, very fast loss of consciousness, but it doesn't deliver much in the way of muscle relaxation. So it doesn't produce that adequate muscle paralysis that we need for surgeries. Midazolam, loss of consciousness within 80 seconds, but it can cause dangerous cardiorespiratory effects. Yes, ma'am.
Just to make sure, are we specifically the prototypics, or is it relating to the specifics for the benzos and the short-acting barbiturates?
Can you say that one more time? What do you?
The prototypic drugs, are these like specific subclasses?
So these aren't. So these are application, right? So we're talking about drugs that are used in a particular application.
Prototypic drug in these cases.
Right. So it's not drug classes in terms of their mechanism of action with prototypes. These are in a particular context of use for general anesthesia. These are the drugs that are most commonly used. Yeah. So propofol is the most commonly used anesthetic, intravenous anesthetic. It produces unconsciousness within 60 seconds, but it's fairly short lasting, 3 to 5 minutes. It has sedative and hypnotic effects, and it can enhance or maintain analgesia, but it doesn't induce analgesia. It can cause profound respiratory depression, profound drop in blood pressure, and increased risk of bacterial infection. High risk for abuse if you can gain access to it. It's not a controlled substance, and supplies are not really closely monitored. Widely available in operating rooms and other hospitals and clinics. It doesn't produce a high necessarily, the kind of high that you would associate with being a drug abuse. But it does produce this instantaneous and brief sleep period, and the person wakes up with this feeling of being energized and refreshed. And many in the waking up feel this sort of euphoria and elation. What celebrity do you think of when you think of Michael Jackson? Yeah. Michael Jackson died from an overdose of propofol. Somebody had a hand up in the back there.
I was just wondering how brief that sleep was.
What's that?
How brief the sedation was.
I think they said 3 to 5 minutes was the, induced within about 60 seconds and then 3 to 5 minutes. Yeah. Etomidate, it's a potent hypnotic agent. It's used for induction. Conscious sedation is the most common application for etomidate. You have increased hypotension with repeated use. It can compromise urinary output. That's what oliguria is, reduced urinary output. Cause electrolyte disturbances. Higher incidence of postoperative nausea and vomiting. Ketamine has dissociative anesthetic effects. It can cause sedation, immobility, anesthesia effects, and amnesia. But it can also cause hallucinations, disturbed dreams, delirium. Okay? So ketamine therapeutic uses anesthesia for young children with very minor procedures, right? So it's enough of an anesthetic and a sedative for minor procedures for young kids. So conscious sedation. It's another example of conscious sedation. Now these combinations of neuroleptic opioid combinations that are used, droperidol plus fentanyl. This is where you have a drug that has sedative effects. It is antipsychotic drugs, but have a sedative effect being used for that effect, combined with a potent analgesic drug like fentanyl. Okay. So the net effect is this indifference to your surroundings. Patient appears to be asleep, but is not in a state of complete loss of consciousness. Okay. Used for diagnostic and minor procedures. It can prolong the QT interval, cause hypotension and respiratory depression. Yes, ma'am.
I'm sorry, what does ketamine that soothing environment?
Yeah.
What does that mean exactly?
I don't know.
Oh, okay.
Yeah, I'm not quite sure. That's the honest truth. I'll get back to you on that. Okay. So fentanyl is an opioid drug. It's a very, very potent opioid drug. It's described as having about 60 to 80 times stronger than morphine and 40 to 50 times stronger than heroin, fentanyl. So we're talking about a very, very strong opioid drug combined with one of these sedatives. Okay. Yes, ma'am. Fentanyl's got a couple of different delivery methods, including a patch that is delivered for acute chronic pain, and it's yeah. Exactly. Cancer patients they have intractable severe pain. Yeah. Yeah. Okay. Yes, ma'am. So twilight sleep, I've only heard it describing scopolamine use. Conscious sedation, I don't believe, I don't know whether that's synonymous. I'm not sure. Yeah. Yep.
I've definitely heard people use twilight sleep to refer to modern procedures, so I think it's just
Right.
sort of a colloquial category.
Right. Right. I don't know the specificity of that description. Yeah. Yes, sir.
I just checked on that ketamine thing, and the book is saying that patients can experience unpleasant psychological reactions, including hallucinations and disturbing dreams. So, I think the soothing environment is probably to keep them in a soothing environment so they don't freak out.
Thank you. Yes. Did you get that? So the soothing and
Under adverse effects.
yeah, I know. That's yes. So it was the antidote to the adverse effect. Yeah, is promoting a soothing environment to reduce the triggering of hallucinations and things like that. Yeah, thank you for that. Yes, ma'am.
I'm just wondering, so we said fentanyl was really, really strong.
Yes.
But we used it for diagnostic and minor procedures.
So it's all about dose, right? So it's all about dose, and also, and we'll talk about it. Fentanyl's got, while it's it is a very strong opioid, it has more specificity and fewer adverse interactions than some of the other opioid drugs. So it's become the drug of choice for a lot of different reasons. Yeah. Okay. Okay. So the analgesics, particularly opioid analgesics, the goal is to reduce pain. Used alone, however, they will not reduce consciousness. And the opioids are the most effective. They're the strongest analgesic drugs that really we have at our disposal. So the term opioid. Yes, ma'am.
Sorry, I just have a question about the last drug. It's still considered general anesthesia, even though it's like not completely lost in consciousness.
So these are intravenous anesthetic drugs that, if delivered along with like an inhaled anesthesia, can be used for general anesthesia. Right. So used alone, so just this combination is going to produce more of a conscious sedation. Right. So it's all about like the inducing general anesthesia is about the combination. Yeah. You're welcome.